patients usually have no difficulty deciding if they prefer low or extra projection spectrum of implants. Normally the patient can help us in taking the final decision about the projection. So form stable implants with varying shapes to give much greater individualization and better final results. However, implant selection has become more demanding. And now we're going to talk about preoperative training. Do you have any questions about the second part? We continue? Okay. The new planning systems are especially important in difficult cases. Where are going to be located the new submammary fold? That is a question. How much skin do we need in the lower pole of the breast? There are two important questions that has to be answered during the preoperative markings. What is the ideal vertical implant position on the thoracic wall in relation to the nipple areolar complex, and how much skin is needed between the nipple and the inframammary fold? Where should be the implant placed in relation to the nipple? For natural appearance, the implant should be centralized under the nipple areolar complex after the augmentation. So, if we think about the new submammary fold, where we're planning the surgery, and we think the nipple in the highest projection, and we take the nipple to the medial border distance, in my method, that is the same distance between the nipple and the new submammary fold. So we have the patient, we have the nipple to the medial border distance. I take that distance to the submammary fold. That's going to be the new submammary fold point, and that is the result. If we put the scar in the new submammary fold, that is the best scar. If we suture the scar without tension, because we have enough skin in the submammary fold, that is the best scar. But if it's not in the right point, and if it's sutured with high tension, that is the worst scar. So we have to think the most important part of the surgery is the new inframammary fold. And that is far away from the axillary point. And then my point of view is far away to work from here and try to do our best here. I prefer to work in the same place. And I know that if I make a correct suture and without tension in the right place, that is going to be the best scar. Even in Spanish patients, that most of them are dark skin, even in Spanish patients. The preoperative markings, the new submammary fold, green color, the submammary fold of the patient, blue color, and there is the pocket dissection limits. I used to detach the pectoralis major muscle until this point, where the new submammary fold ends, not in this part, because if we cut the pectoralis in this part, the implant is going to be visible, and you can palpate it. I only cut the muscle until this point here, and there is the mammary distance, the upper part of the pocket dissection, not over the axillary vertex, and we also have a mark in the lateral part. The incision is going normally to be between 4.5 or 5 centimeters, normally 4.5.
Sorry, can you go back one?
Yeah.
Well, how do you measure your upper red markings?
That?
Yes.
Okay.
That's the upper part of your pocket. How do you?
The vertex of the axillary.
It's always?
Yes. I don't make any dissection over this point. From this point to the clavicular area, never. That is the bottom of the pocket. That point.
That's always the axilla.
Yeah, that point. Depending on the projection of the implant, if we take different measurement between a low to extra projection implant, the nipple elevation is not, there is not a lot of difference. It is between 2 and 5 millimeters. It's just the same that stretching the arm a little bit extra. With the implant wide, it is proportional to the chest, that is 2-3 centimeters in the mammary distance. The same amount of nipple elevation in all cases. So we cannot elevate the nipple with an implant, but we can perform a mastopexy. Why? And there is another conference I presented in Brazil 6 months ago. The concept of mastopexy is not the distance between the sternum node and the nipple. A mastopexy is a concept of shape of the breast. If we change the shape of the breast, and we change the position between the nipple and the submammary fold, we are doing a mastopexy, even the distance is the same. We don't need, because there was some questions saying, how much do you elevate the nipple when you do the breast mastopexy only with a high projected implant? I said, nothing, it's the same distance. So you're not doing a mastopexy. Yes, I'm doing a mastopexy because I'm changing the position of the nipple, the relation between the nipple and the inframammary fold in the preoperatory and in the postoperatory, because the nipple is a little bit upper, but the distance is the same. The first case for tomorrow is a dual plane 3 with high projected anatomical implant. How much skin is needed between the nipple and the inframammary fold? Well, it's a little bit complicated. I have studied that, but it's more simple than in the presentation. It's influenced by wide projection of the implant, the amount of glandular tissue, and the envelope characteristics. We're now thinking about the low ventral curve, which is the distance between the ideal nipple projection, which is this point, and the lower implant border, which is this point. That is the skin we need to cover the low ventral curve, adding the distance of, depending on the glandular tissue. So we have to add that distance to the glandular tissue to know exactly how much skin we need in this part. The distance must be adjusted to the implant dimensions. For example, it's different, 775 grams, we need 16 centimeters high, and we have 12.1 centimeters of low ventral curve.